This
we have
conference
our
will now
administrative
be
course going.
recorded.
All right.
And yeah, we have our administrative course going, and so I was trying to get that started as well. And then we had a state senator pop in, so I had to take care of a little bit of that. So you know how crazy mornings get going. So
Right.
anyway, I'm here now.
We have a couple that will probably show up in class a little bit later because they had a flat tire on the way in. Most of them are here. All right, it's all yours.
Well, you know, in our world, and you guys will soon figure that out, life happens. And so you just kind of have to go with the flow, right, Z? All right. My name's Melissa Holland. I'm the executive director of the Oklahoma Assisted Living Association. And I am happy to be here to talk to you guys and give you a little bit of history about, history and also some knowledge about assisted living in Oklahoma. So let me make sure this goes. So in Oklahoma, there are a lot of different options of long-term care. And so first I want to kind of let you know just a little bit about those, and you guys are learning those at this time. The first is, of course, our nursing homes. And you guys know that that is a nursing facility that provides 24-hour skilled nursing and related services for residents who require medical or nursing care pretty much 24/7. And that became like basically their birthday was October 1st, 1980. That is when our lawmakers put that into law. And that was under the Nursing Home Care Act, and it is licensed by the Oklahoma State Department of Health. And that requires a certificate of need. And I know you guys have been kind of talking about that some, but one of the things I want you to understand is a certificate of need. If you own nursing homes and you own kind of like beds, that is deemed, think of it as that is kind of like oil royalty rights. And so you will see sometimes that nursing homes in rural areas or something, they may still have those licensed homes, but they may not be open because that is royalty rights. You know, that's like oil royalties. And so they can actually sell those beds because they already had that certificate of need. And so it's hard sometimes to get the state to say that there is still a certificate of need out there for more beds. So just in case you guys ever wonder about that, while you may see that a home is still on the list as being that those beds are still licensed, but there's no one there, that is kind of why that's still up there. And then they do have the options for Medicare and Medicaid. The next is your residential care. So that was what next came into law. And so that is to provide resident services and support assistance. And it may also provide assistance with meals, dressing, bathing, and other personal needs, such as medication administration. However, they cannot provide medical care such as a skilled nursing need. So it is basically they're going to be getting medication assistance, and a lot of them actually go out for a day treatment. Some of them you'll see like a lot of veterans in there that have maybe PTSD, or you see a lot of individuals that have maybe some mental issues in residential care homes. To be in there, you have to at least be 18 years of age. So they came into law November 1st of 1984, and that was under the Residential Care Act. And they do not need a certificate of need. And there are no options for Medicare or Medicaid in residential care. So next came the Adult Daycare Center. And that does provide health, recreational, social, and supportive services to impaired adults for more than 4 hours per day. But those participants do not stay in the center overnight. And that came about November 1st of 1989, and that was under the Adult Daycare Act. They're also licensed by the Oklahoma State Department of Health, and no certificate of need is required for that as well. And there is no Medicare or Medicaid option. However, through the DHS, there can be the Advantage waiver that can help pay for that. And then came along the assisted living communities, and that's a home or establishment that may provide assistance with personal care, medication, ambulation, nursing supervision, intermittent or unscheduled nursing care, but they cannot provide 24-hour skilled nursing care like constantly. And our birthday is May 20th of 1997. And that was under the Continuum of Care and Assisted Living Act, which is licensed by Oklahoma State Department of Health, and there's no certificate of need required for that. And no Medicare or Medicaid option. However, through the DHS, there are a few homes that have the Advantage waiver. So more, well, the continuum of care facility, and that's where that combines the services of the nursing facility with an assisted living or adult daycare. Just kind of a note, currently all continuum of cares in Oklahoma, they all have assisted livings. None of them have an adult daycare right now. So, and that again was the same birthday of May 20th of 1997, the Continuum of Care and Assisted Living Act, licensed by the state health department. The options for Medicare and Medicaid are for nursing home, that nursing home portion only. And the certificate of need is required for the nursing home portion. So if you're going to do that, you have to get that certificate of need for your nursing home or skilled portion first. And then the veteran centers, these actually came about in 2013, which I think it was after a lot of, you were seeing a lot of bad reports in the news of the veteran centers, though we didn't have any oversight. And so this program is for residents who are veterans living in the state's veteran centers, and they are licensed as a nursing facility, and they can provide that 24-hour skilled care, which is related for residents who require medical or nursing needs. And that happened May 29th of 2013. And this falls underneath the Nursing Home Care Act. They're licensed by the health department. They do have a few little differences though, because they do not have to have a certificate of need, nor are they required to get any future certificate of needs if shall they decide to open another one. And then there's what is called independent senior living out there. And that is apartments, cottages, and single family homes for seniors 55 and older who do not require assistance with daily activities or 24 skilled nursing, but may benefit for convenient services, senior friendly surroundings, and increased social opportunities. And you guys are going to see these popping up more and more. However, their care seems to be higher and higher acuity. They're not licensed by the health department, but they may receive home health and hospice services. And our office continues to get calls from loved ones who thought that they were moving family members into, say, assisted living, but it actually was an independent senior living, and they were upset that, you know, there was no oversight with the health department. So we have a flyer that we kind of use on this to help educate people so that they do understand these options. So now let's talk about regulations versus rules, because you guys are getting all kinds of information overload. And so this is something that in our class, I kind of like to help them understand a little bit, because sometimes you'll hear, you know, a regulation or a rule or title or act and all of that. And so this is something just to kind of help you understand. So what is a regulation and what is a rule? So regulations are the law. So that is what our lawmakers say they put into effect. And with nursing home regulations, you also have federal regulations. Assisted livings, we don't necessarily have them unless it has to do with, say, like OSHA or employment laws, you know, things like that, that are kind of a universal law, but not specific to the assisted living caring for our seniors. So the state legislators, they write this into law and what we must follow. But also sometimes you're going to hear it referred to as an act. And then it's usually brief and not defined in extensive detail because they are not the experts in what they're writing into law. They're going to give it to whoever they want the expert to write the rules about it. So Rules also must be followed. What the legislators usually will do is they're going to write that who will promulgate the rules of the act. And so, such as like Ospelka, they'll put that they will promulgate rules for the administrators on how you are to follow certain things. And so that's why the rules are much more extensive than what the act is that has basically made Osbelka a board. And then typically regulation sometimes trumps rules, but the rules actually, usually there's no, they follow it exactly, but sometimes they don't catch up. And so, but usually the rules follow them exactly. So here's some more important dates for assisted living, which we kind of covered a little bit earlier. That was kind of the birthday of assisted living in Oklahoma when we became law. And then June 25th of 1998, so more than a year later, is when the Oklahoma Board of Health adopted their rules, or, promulgated those rules for licensure for the continuum of care facilities and assisted living centers. So it took them over a year to write the rules for us. Then June 25th of 2007, they amended the rules to become effective regarding plan of accommodations. So that would allow our residents to age in place. So they had been living there for 10 years and decided, I don't want to move out, I want to stay here. And so that's when rules, they put those into place. But then shortly thereafter, about a year after, the state fire marshal said, oh, hold up, wait up. Okay, if you're going to age in place, we need to make sure that the occupancy codes, it will reflect your plans of accommodation for certain disabled residents, because a lot of the assisted livings had been residential cares that had been built like I-1, not I-2, and they had grandfathered in. And so they needed to ensure that they had system or codes in place that residents that needed assistance in evacuating had the correct safety measures should there be a fire, i.e. Sprinkler systems, certain things like that. In assisted living, we didn't really need the hallways to be as wide because we don't have hospital beds like nursing homes do, but there were certain things that needed to be put into place to where you could be kind of grandfathered in to be considered an I-2 versus the I-1, so that we could help assist residents in the event we needed to evacuate. And then November 1st, the laws were amended that had required assisted living administrators for us to be licensed by the Oklahoma State Board of Examiners, by OSPELCA. This also included the residential care as well as adult daycare administrators. And then on November 1st of 2013, this is one of the rules that Ocala did, is we amended the law to add informal dispute resolution. We did not have that like nursing homes do. So when we had a survey, it's kind of like you get what you get, and then you just move on. And so we got to add that into our law. And then November 1st of 2016, we also we amended it to address some scope and severity during the survey. This also addressed not being able to fine under residents' right tags for unrelated deficient practices. So, because as you guys know, if you're tagged, everything can go underneath a resident's right. So we were never clearing because they would always put a resident's right, a resident's right. And so then fines started happening. And so what it had to be is like, if you, your initial tag was for the maybe medication administration, you came back and they cleared that tag, but yet you got another tag for maybe laundry services, but you didn't clear residents' rights, those are two totally different situations. And so that is how we wanted the related practice to be where fines would then start. So we address that in law. And then on November 1st, we amended the law so that OSBELCA could add electronic testing options for the state standard exams. We were having a lot of like regional directors that were getting their administrators options, and maybe they were from out of state. And so it was just hard for them to travel in. And so it was easier to be able to add that so that they could go to a PSI and maybe their state to take the state standards exam. And that's for all like nursing home and adult day and residential care now too. I think all of them can do that too. And then November 1st of 2019, we had the law amended to make up OSBELCA that required to have at least 3 years of experience as an administrator in the facility type they represent, except for nursing homes. They still require at least that 5 years. We just found that, especially like in the adult day and residential care, where there were fewer facilities out there, that it was harder and harder to find people that could serve on OSBELCA. Plus, we wanted to ensure that who was serving in those roles actually had been an actual administrator in the type that they were serving as, so that they understood, the day-to-day operations and bring that expertise to the board. So why the need for assisted living in Oklahoma? So why did we need that when it came about? And that was all about consumer choice. So care plans and room settings could be adjusted for each resident's needs and capabilities. So as people were aging, they might not have to move when they start to, need more care. And so in the beginning, it was either the residential care or it was your nursing home setting. So this actually just allowed another step to help choose a living arrangement that met their expectations for independency and privacy. And then it also allowed for provider flexibility. So with, like I was saying, the existing residential care and nursing facility providers, they could continue to operate under their current license, or they could step up to meet requirements for the new licensure type. So a lot of those residential cares did step up and decide that they were going to do assisted living and care for seniors. And then some of the residential care continued to do people that were 18 and over and care for them. But also residents with the continuum of care, they could actually adapt their care plans and their physical plans so that residents didn't have to be discharged should they need some short-term variations in their health care, like to ambulate, say someone either had a surgery or had fallen and broken their hip, they could actually go to the skills and get that short-term care and then come back to their assisted living, which had become their home. So here's some facts about assisted living. So all assisted livings are regulated at the state level. So that is true across the United States. So each state is different by state. But Oklahoma is one of the most regulated states for assisted living, and that is not a bad thing. I look at Texas sometimes and it's scary to me because in medication administration, and I don't know if there's very many nurses in this class, but in Texas, basically anybody off the street can come in and the nurse will in service on how to give medications, and then they can start giving medications in assisted living. And I don't know about you guys, but that scares me. And so I like our regulations. I like that, to know that our seniors are being taken very well cared for. And we also are the only state that has residential care. So in other states, residential care is used synonymously as assisted living. So whenever people come in from out of state and they're taking our course, I have to kind of clarify with them what they're wanting to do, because a lot of them are wanting to come in and they want to purchase like a 3-bedroom or 4-bedroom house, and they want to take care of seniors, but they're calling it residential care. And it's a big difference on licensure versus what they're wanting to do. So there's a big education process in that. And that's also why our licenses are our CAL license, which is the Residential Care Assisted Living license. And that's how NAV does that, because in other states, residential care is basically the same as assisted living. I got ahead of myself, so I apologize for that. And I don't know what I just did. Okay, there we go. And then keep in mind, if you have seen one assisted living, you have only seen one. So even if they're owned by the same company, say like Brookdale's, which we kind of tease them that they're like Starbucks, there's one on every corner. But even one of those, they're different because of the culture that's created in each one of them. Their residents help create that culture in there. So if you've seen one, you've only seen one. And memory care is not a separate license in Oklahoma, and that's going to be the same for you in nursing homes. So if you have memory care, it's still umbrellaed underneath your nursing home license. There is, I'm just going to say right now, there is a lot going on with Alzheimer's Association and some legislation about when you do your licensure form and if you're going to have memory care. There is like an addendum, and then there is a disclosure form that you give when people ask about that. And so there's a lot going on about that. So just keep that in mind, that there may be some new things that you're going to need to learn if should that pass. So, but memory care is not a separate license, but you do have to fill out an addendum form if you're going to have it. And you need to send that to your ombudsman, and then anyone that asks about your memory care, this is something that you need to be sure that you give to them. So if your, say if your company fills it out for your licensure and sends that in, you as an administrator, you need to make sure you know what they've sent in, and you need to have that as part of your marketing material. And so you know what they've said you're going to do different in your memory care, that, you know, to make that memory care special. So what is the definition of assisted living? So that means a home or establishment that coordinates or provides services to two or more persons that basically live there, and they're not related to the operator, and they, by choice or function impairments, need assistance with personal care or nursing supervision. They might need intermittent or unscheduled nursing care, and they may need medication assistance. I kind of laugh at that one because pretty much every one of them need it, because that's why they move in. They may need assistance with transfer or ambulation. And intermittent, I've kind of put this little note in there because intermittent nursing care and home health aid services may be provided in the assisted living facility by a home health agency. And so I like to tell people that home health are like our best friends, because if they need that, that's who we rely on to provide that. So now I'm going to give you a little bit of statistics on assisted living. We are the fastest growing long-term care. So in 2008, there were 117 communities with 6,753 beds. Now, keep in mind that we, in assisted living, we will license additional beds in case like a husband and wife come to move in, but each room is not, we're not going to always have double occupancy in there at all. So even though you see those beds, that does not mean people. In 2019, we had 184 assisted living communities and 11,186 licensed beds. A huge growth difference there. So that was an increase of 67 communities and 4,433 beds. I'm still waiting for the final numbers to come out from 2020 so I can update my slide in case you're kind of wondering from the state health department. So when they do those, like their year end ends June 30th of 2020, but they don't publish the results until the January of the following year. And it's like at the end in February or somewhere like that. And with COVID and stuff, they're kind of behind. So I don't have those final results. So the average assisted living is 59 beds. And that is probably, just so you guys kind of, that's probably like a 40-door assisted living community. And then the largest assisted living is 166 beds. And that is probably, that may be around 100 to 125 doors. And then the smallest is a 5-bed. And that's what I was talking about a little bit earlier. That is actually a 3-bedroom house that is in a residential setting. So what care and services are provided in assisted living? So usually you will have, one of the things that our law, well, our rules are a little gray, but it says we shall not care for any resident needing care in excess of the level that we are licensed or capable of providing. And so let's talk about that a little bit, because whenever you fill out your licensure application on that, you're going to say what you're going to take care of. So some assisted living say, I'm not going to do incontinence. So if they become incontinent, then, we will talk with them and they may have to move out. I'm not going to do aging in place. And some do that, but some don't. Some say, we will take care of a 2-person assist. And so I caution them on that, because if they're going to have a 2-person assist, that means they have to have 2 people dedicated for that one resident in the event of emergency. And then they have to have enough staff for everybody else. So, okay, so you have one person that's a 2-person assist. But what if you have 2 people that are 2-person assists? That means you have 4 staff designated for those 2 people and then enough staff for everybody else. That maybe get challenging with call-ins, and all of us know staffing can be a challenge. So that is the capable of providing. So you may have good intentions of providing that care, but sometimes you may not be capable of providing that care, whether it's call-ins or whatever. So keep that in mind. You also have to ensure routines of care and delivery are directed by the resident to the maximum extent possible. And I can tell you that in our top 10 deficiencies, this has been started to be cited a lot more often. So making sure that that resident is a part of it. So to be admitted into an assisted living, it's kind of hard. It's, you guys, I mean, like for a nursing home, it's a lot easier, but for us, one of the things that we have to do is we have to have the description of what we're going to do to be based on the following areas. So we have to put in our contract the personal care assistance, what nursing supervision is going to happen, and then intermittent, or if they have intermittent or unscheduled nursing care, how are we going to meet that? And then any medical, the medication administration, how that's going to happen. And then assistance with transfer and ambulation, as well as assistance with cognitive and services with Alzheimer's disease and resident, related dementia, which I kind of talked about that one a little bit earlier. So all of this description has to be put into our contracts and into marketing material. Then you have to also, this goes into your application for your license, and I talked about the contract, and then you have to put in there also how the assistance with your personal care, meals, housekeeping, and laundry, your nursing supervision during nursing interventions, and this is the RN supervision piece. So how is that going to happen? And then intermittent or unscheduled nursing care as defined in Chapter 310. And that Chapter 310 are the rules: medication administration, assistance with your cognitive orientation. And again, we're talking about the Alzheimer's 2 disease. And then assistance with transfer ambulation, plan programs for socialization, activities, and exercise. And then provisions for evacuation of the building structure and staff to meet that, and which I kind of touched on that a little bit earlier. Okay, so I do have a little joke in here, so I want everybody to laugh. I want to hear you laughing. So resident admissions. No, you know, our seniors are funny, and they always use funny words. And one of them that I really like is whippersnapper. I think that's kind of cute. But anyway, so senior citizens, you know, no whippersnappers allowed. So are you laughing, guys? I'm trying to look. Okay, we'll move on. So what do we have to admit someone into our assisted living? So the following has to happen. You have to have a resident assessment. And the only person that can do this assessment is a nurse. So an LPN can gather that information, but the RN is the only person that can do the actual assessment. And then you have to have a physician plan of care. And what's funny is one time my dad was going to go into an assisted living after he'd had hip surgery just to do like a little stay for a while. And we had the physician plan of care, and the doctor came in and he looks at me and he goes, well, who fills that out? So physicians don't want to fill that out. Usually they send to nursing homes just their orders, you know, and that's what you guys use. Well, we have to have this physician plan of care. So typically the nurse is going to fill this out and the physician will actually sign it. So, but it is pretty lengthy, but basically it's kind of like the orders that they send to you, but we have a different form that has to be filled out on. And then you have to have your resident contract, which is similar to like if you're moving into an apartment, but except for it also has how we're going to meet those needs, like what we talked about earlier. And then you'll have to get the entrance fee and rent. So you have to have all of these steps before they can actually move in. There also is a difference between their actual contract move-in date and then their physical move-in date. So what staff is actually required by rules and regulations? So the nurse, but whenever I talk about a nurse, that is that RN that has to be there. So we're not technically required to have like an LPN 24/7 or even, you know, 5 days a week or an on-call, but most assisted livings do that now just because of the acuity and how it's been going. And so we keep that going. Sorry, I was just checking my time. And then medication staff, you have to have medication staff 24/7, you know, to be able to give the medications. An administrator, and then a dietary consultant, and that is only if you're offering specialized diets. Most places just do like a heart healthy diet, and then they would do like modified diets. I mean, not modified, but like texture modifications. And so they wouldn't technically need that dietary consultant. But if you are going to do that, you would need that. And then the qualifications for our staff. Of course, everyone has to pass the National Fingerprint background check. And then if they're providing socialization, they must be trained. So that would be like your activity director. So you just have to be trained. We don't have to do like all the documentation and the things like nursing homes have to do, but there has to be some training. And if there's a specialized unit, they do have to be trained prior to working on that unit. And that specialized unit is your Alzheimer or dementia unit. And then your direct care staff has to be trained in first aid and CPR. And then all staff must have that 1 hour of dementia training per year. And that's also the same for nursing homes. This is every, like all long-term care, even like hospice, home health, and everything. This was a new law that kind of went into place. So what are the minimum staff requirements in assisted living? This is kind of funny because not too long ago, we received a call at the office that it was from a direct care worker that was upset because they worked in a nursing home and their friend worked in an assisted living, and their friend they were understaffed, way understaffed, because they did not have a ratio whatsoever. You know, they needed more staff. Well, we don't have ratios to residents. Ours just says adequate trained staff shall be on duty 24/7. So we have to staff to the acuity of what we have and to meet the needs. And so if the needs are not being met, we are not adequately staffing. So that was something I was explaining to this person, because they felt like there should be, you know, so many more staff members because of the number of residents, but the acuity didn't require that many staff. So unfortunately, and I think it was like a CMA that was used to only working on a cart, and they were actually having to maybe help assist some residents. And so I think it was kind of along that line. But anyway, if you have a one-person staffing, you can do that. Usually you would only see that in, say, remember I was talking about that little 5-bed home, but really it's a 3-bedroom. You might see that at night in a 5-bedroom in that situation, or maybe in a startup. But if you do that, you do have to have that like in your contract. The health department has to know about it, and obviously the residents and everything, and that person has to be able to administer medications. And then the staffing units that limit access. So if you have like a wing that is like your dementia care or something like that, you have to have enough staff in there. You can't share in between the two, you know, the other area as well as that, and it has to be someone that can administer medication. So a typical staffing in assisted living. So on your management, usually you'll see an administrator, activity director, a dietary supervisor, a nurse, which they kind of call them director of wellness, usually a marketing director and a maintenance director. Some maintenance directors are kind of shared between. It just depends on how large it is. And then at a minimum, the direct care staff, you'll see like an ACMA or CMA per shift, at least a CNA, and then a cook, 1 per day. And these are on your smaller ones. And then larger communities, they may add in a business office manager, housekeeper, laundry aide, and then a resident care coordinator. And that might be either an LPN or an ACMA, and a dietary aide. So our administrators they do not have a lot of help. I mean, it's like they're working administrators. But this is kind of what you see and what you have in your assisted livings. So what is the cost of assisted living? Because most of it is private pay. So the average cost is around $3,800 for a private room. It's just going to be based off of the size and where you're at, if you're in the metro or if you're in maybe a rural area. Financial assistance, there is a little bit. There is some long-term care insurance, the VA aid and attendance. Tribal assistance, there are a lot of tribes that help their elders, but it's different between each tribe. Whenever I was an administrator, I did have a resident, and her tribe sent a check to us each month. And then the Advantage waiver, that's with the Department of Human Services, as well as there's a life care funding group that basically you kind of sign over your life insurance, and then, I mean, they'll pay for it, but so there is some of that. And how is it figured? How is the cost figured? So usually you're going to have a basic rate, and that again is based off of the room style you choose. Usually it's your basic services, and then we're going to go over those in just a little bit. And then you may have a care rate. And so different companies charge different ways. Some do, some are all inclusive, and some are a la carte. So there's just however what fits your needs on that. Additional services may include room tray service, extra laundry, extra housekeeping, family meals. So let's talk a little bit about that extra service on the room tray. I had a resident that her family invented, so you know the big round hay bales. So that big old poker thing that's on the back of the truck. So her family invented that, and she was so sweet. But she always wanted breakfast in bed, and they wanted her to have that, so they paid extra every morning for her to have breakfast in bed. So that was kind of a fun thing for us. But anyway, so personal care products. So medication costs that's not maybe covered by insurance, incontinence products, so we don't provide those, and toiletries, including toilet paper. So we don't supply toilet paper in their bathrooms. So they have to, so all their personal care products, that, you know, they'll have to have that or be brought in. So what services and amenities are provided? So your basic services usually are your 24-hour staffing to meet your scheduled and unscheduled needs, 3 meals a day and snacks in between meals, housekeeping services in your private room, and then scheduled transportation, scheduled activities, emergency call system if it's in the contract, which most of those are. So some of the basic amenities that you're going to see are private and or semi-private rooms, a private bath or semi-private bathrooms. Usually those semi-privates are in like memory cares, common living areas, a dining room or rooms. And then you'll have, oops, my laser pointer keeps getting off, an activity room, the laundry room, barber shop, but even in those barber shops, you usually have to pay separately to the beautician on that. Others you might see is like a spa bathroom, the theater room. I mean, they're getting fancy here. Private dining, chapel, safe rooms, library, a gym exercise room, and coffee bar and bistros. So game room, there, I mean, there's some pretty nice places out there for you to go and see. And some even have indoor swimming pools. So what causes move outs? So why do residents move out of assisted livings? Well, you know, one is death. I mean, that does happen. The other might be their acuity. Acuity may be too much, but sometimes they get better and they go back home. Financial. Some may have, they just ran out of money. Usually when that occurs, if they've lived there a long time, a lot of assisted livings work some deals out with them. It's not going to be like, I mean, we do have some hearts here. I mean, they do try to work that out. Dissatisfied, and that could come from not receiving the care services they thought they were going to get. It could be unhappy with staff. It could be that they don't like the food. And I always told my staff that if you make their bellies happy, then they're going to be happy. You know, they may forgive some other things, but food is hard to make people happy with sometimes. And some may be other residents. Sometimes you have bullies in your community. I actually had at our last conference, I had our state ombudsman, Bill Whited, do a presentation on how to help if you have some, you know, for a lack of better word, mean residents, because sometimes that does happen. Because if you got in their spots, it's just like church, they have their spots in the dining room. And so how to avoid some of those issues. I had, for instance, I had out in Western Oklahoma when I was a regional marketing director, I had a community that they were really mean to one of one of my new move-ins because they felt like she did not dress appropriately for the dinner meal. They felt like everyone should dress up nicer for the dinner meal, and they were not very nice to her. And so we really had to work with not only them, but with her, and because she came from the farm and they were kind of from the city life, if it can be so out there. And it was really sad. It was a sad situation. We did kind of get it worked out, but we needed them to both see each other's feelings on it and how it was affecting them, especially the ones that were so mean about it. I just was kind of appalled. So, but that can happen. And no activities if those aren't going on. Um, and sometimes, also on dissatisfaction, let me just add, sometimes no matter what you do, you may not be able to meet someone's needs. They just may never be satisfied. So, and sometimes location. So sometimes when they moved in, it was a good location, but now the daughter has moved back to the city and it's on the south side and she's on the north side, so they want her closer to them. So sometimes that happens, and just kind of a little example of that. So sometimes they want to move closer to a child. So some of our top survey, like what we are cited for, I just wanted to kind of let you know a little bit about that real quick, so you can see what we are, what's going on there. Was staff qualifications. So we had a few assisted living centers that were not, they didn't have all their staff trained in first aid CPR. So I know in nursing homes, you guys need to have them certified. And this is easy. This should be a no-brainer as an administrator. If you were to get this, I don't think I would admit if I had to get this, because this is simply a checklist. I mean, this is something you guys should always be checking monthly to make sure all your staff are current on this. So, but it hadn't been in the top 10 for a while, but it came back. The use of assessment. And so you need to use this residence assessments to develop their care plan in consultation with the resident. And I kind of mentioned that earlier in the beginning of the thing. And so they are starting to cite that. And it may be happening in nursing homes as well. So make sure that the residents are getting their choice in developing their care plan and how, their goals and what they want to achieve. So number 8 was the criminal history background check. And this was a little hot point. And I'm going to tell you what this was about. This is about, because on the OK screen, and this will apply to you guys as well, if you go back in and you're doing a rehire of someone, it is going to say, this is a duplicate. Do you want to continue? And so your answer is always going to be yes, you want to continue. Because if you don't, then you're not going to redo their background check and you need to do it. Some of our members, this is how we kind of figured that one out, is that they thought, oh, I already ran it. I didn't realize I'd already ran it. And so they didn't continue, but they had ran it when they previously worked for them. So make sure you continue through that process and rerun that background check, because that's how this kind of got caught. And the next is maintenance of records. They have to be organized, accurate, and clinical. I think there were some assisted livings that may have been without nurses for a while. That's kind of what I could see whenever I was going through a lot of the surveys. And it just really looked like they did a poor job of not keeping up with residents' records. And it was not good. So on that one. Then residents' rights, and as we talked about, almost everything can be done under residents' rights. This one actually was not in the top 10 for a couple of years, but it now came back in, and it had to be from, this one is about the free from mental and physical abuse, neglect, restraints, chemical restraints, medical symptoms for the physician, and it had to, actually be not, they were not notifying the physician within 24 hours of using a medication. And then assessment timeframes. This was, we have to have the comprehensive assessment. You have to do the 14-day after admission, and then once every 12 months thereafter, or after a significant change in resident. And this kind of goes back to the one before when I was talking about the maintenance and records. That same, there was a couple of places, that same places did not have their assessments done timely. And so this is exactly what this was about. And then food storage, preparation, and service. This is always in the top 10. And you guys, it's a huge chapter. As an administrator, my advice to you is trust, but verify. And write this down. So get out your pens. I want you to write this down. These are some things that you need to keep in your desk at all times. Hairnets. So keep a few extra hairnets in your desk. Sharpie pens, because they walk out of the kitchen. And then a food thermometer. Have that backup in your desk at all times. The other thing that you need to check on a regular basis is in your kitchen on whenever you have your the dishwasher. If you're using those little sanitizer strips, they expire quickly. And so you need to check that expiration date, because there's nothing worse than having a great survey and then you get cited in dietary for some of these few things. One is maybe someone not having a hairnet on. And so if you, and they say, well, we are out of them. So you have some of those there. You can get that taken care of quickly when you know the surveyor comes in. A lot of people have code words like the eagle has landed or something else. So, you know, pick your code word so all staff know, but know not to freak out. But so use those things. And then the Sharpie pens, those are for you to label and date everything, including everything in the kitchen. Make sure that is done. So like if surveyors are coming in, they've come in, you need to make sure someone is on top of that. Also, they're not going to buy it if your temperature logs are in the same handwriting and they look perfect and clean and everything. That's falsification of records. So you need to make sure that you are checking your food temps either daily or weekly, or you're checking those. That's my trust but verify. And they should be messy sheets of paper. They're not supposed to be clean and perfect papers. And these are some of the #1 items that get tagged across the board in all long-term care services. And they're easy things to take care of. And the food temps, you know, if someone doesn't have their thermometer. So, got it? Okay, I'll move along then. And then care and services, that's your coordination of care. Again, we talked a little bit about this earlier, that you cannot care for someone in excess of the level or capable of providing. So you need to monitor. One of these things is if you're going to have home health or hospice services, because you're not you're allowing someone to age in place, and so you've brought this in, you've done a plan of accommodation, you need to monitor and ensure that the delivery of that home service is happening. And then #2 was the medication staffing. And so you shall provide or arrange qualified staff to administer medications based on the needs of the residents. But you also have to make sure that the medications are reviewed monthly by a registered nurse. And then we also have to have quarterly pharmacist consultants that look at that. One of the things on this that was tagged, and this is something that you guys may make note of this, is that when you've gone to the Mars and the stuff that's online, make sure there is a way that if your nurse or someone is reviewing it, that you can prove that it has been reviewed, even though it's online, even though you have those MARs and everything online. You need to have a system so that it shows that it has been reviewed monthly. And then the number one, which this has been the number one for like 5 years, and that is residents' rights, but that is that they have the right to receive adequate and appropriate medical care, be fully informed and participate in the planning of care, and the right to refuse medication and treatment. So this is something that, when you get tagged for something, then you're also going to get tagged for that. This is one of those things. So now I'm going to do a little comparison, and it's not really versus nursing home, but it's just a little comparison for you about assisted living versus nursing home. And so to help you kind of understand some of the differences. So we're regulated at the state level, which nursing home is, but you also have Title 19, which is your federal regulations. Then we mainly deal with residents. You guys mainly deal with their family members when they're coming in. We have a home-like environment. We want that to make their home. Yours is more institutional environment. However, a lot of makeovers have been happening in the nursing homes, and they're really looking beautiful. I've gone into some. Occasional skilled nursing can happen like through a home health, say if they're rehabbing, but you can provide the 24 licensed nursing needs. We're primarily private pay. You have the Medicare, Medicaid. We have a licensed nurse on call 24/7. They may be in there, 40 hours a week, but you have licensed nurses on each shift. We are not required to have an employee to resident ratio, but you do. You have higher employee to resident ratio, which is determined by your regulations. We do not have MDS, and you do have an MDS. And no certificate of need, no RN consultant. You do have the certificate of need, and your DON is usually your RN. Here's some other facts just in comparison about like whenever I did how we've grown. So 2008, we had 117, nursing homes 317. 2020, we had 184, and nursing homes 304. I think that was the end of the number of that one. So so there has been a loss. The reason why I have that little asterisk in there is it does not include the VA center. So on the average, so the assisted living increased by 67. So average bed is 59. Nursing homes, they did decrease by 13, which their average nursing home beds are 93. The largest assisted living is 166. Largest nursing home is 375. And then the smallest is 5-bed, and the smallest nursing home is an 8-bed. And I believe that's like one in Eastern Oklahoma that is, it's a specialty one. I can't remember what it is. But yeah, it does not include nursing homes or the specialized facilities. So on that, a little bit more comparisons. Guess I did get the 2020 numbers. I'm sorry about that, guys. So surveys, we had 357, and compared to 2018, which is a decrease of 103 from last year, a decrease of 61 from last year. So approximately 1.94 per community, and yours were approximately 7.29 visits per home. So a lot more were going to your nursing homes than assisted livings. On that comparison, number of complaint surveys were 89, which decreased to 58 from last year, and then approximately about 0.48 per community. And then the number of complaint surveys for nursing homes were 961, which was an increase of 6 from last year, but that's approximately 3.16 per 16 per home. So just some little stats there. I have an accounting degree and I like stats and looking at things like that, but just to kind of give you an idea of some things. Some homes may have 0, but this I just put in the number of homes and assisted livings and how that worked. And let's see. Okay, so this is a little slide that I did a while back. Are you safe from COVID in long-term care? And so for individuals in Oklahoma, a lot of people say, if you're 65, are you safe? And many ask that. And you're much safer in assisted living in Oklahoma as well as nursing homes. So if you do the numbers, like with the total deaths and facilities with COVID, and these are actually some old stats. So, whoops, I didn't mean to go that fast. Sorry, let's go back. Assisted livings, like at the time that I did this, they had 44 deaths, nursing homes 24, CCRCs 19, residential care 0. But if you'll look at that compared to all the deaths of 65 and older, so you are much safer in a long-term care than you were not in a long-term care. So in case anyone ever asks, yes, you are much safer in a long-term care facility than you would be staying at home. So just a little FYI on that one. Any questions for me? I'm at my hour. I think I went a little over, so if Z, I'm sorry about that, but any questions? And which I guess you'll have to ask, or if someone, because I've not ever done this via Zoom, but